This episode of The Dental Guys is brought to you by the Dental Crafters Network, your implant restorative connection. From surgical planning to patient-specific guides, quality implants, and final restorations, the Dental Crafters Network provides one relationship with infinite possibilities. Call 1-800-472-8302 today. That's 1-800-472-8302.
You're listening to The Dental Guys, episode 49. The Maxilla is the Wild West. Spear Education's own Darin Dichter joins Jon and Wes to discuss why he's so passionate about treating edentulous cases. Did you know the position of 8 and 9 can tell you what implant restoration you need in the mandible? Is adding more implants always the right move? We want to save your implant case before it even starts this week on The Dental Guys.
Welcome to this week's episode of The Dental Guys. I'm Jon the Dental Guy.
And I'm Wes the Dental Guy.
And we'd like to introduce you guys to a very special guest we have today with us. And Darin, make sure I say your last name correct. So, pronounce it for me.
Don't mess yourself up, Jon.
It's actually Dichter.
Yeah. Okay, I wanted to make
Dichter.
sure because you guys that have seen Darin out at Spear, he is teaching some really exciting courses out there. And Darin, before we get into that, just tell us a little bit about kind of who you are, where you're from, where you went to dental school, and how you got involved with Spear Education.
Oh, great. Yeah, thanks. I grew up in the Northwest. I'm kind of an Oregon native. I grew up on the coast, and I went to dental school at Oregon, did my undergrad at University of Oregon. When I graduated from dental school, I went straight into private practice. So I spent a year working with my family dentist, and then I opened a practice from scratch in a town of, at the time, just around 1,000 people. So I was out there for about 10 years, ended up selling that practice, and I moved to Portland. I was in Portland for about 6 years before I kind of wrapped that all up and went into a full-time pros residency at UCLA.
Okay. And then you had mentioned to me earlier as we were talking before the show that you knew a lot of the people that are now involved at Spear Education from different backgrounds. You tell us a little bit about how you got connected.
Yeah, I was always really active with continuing education. And when I was in Oregon, I was actually involved with the Oregon Academy of General Dentistry. I did a lot of stuff with setting up workshops and programs with those guys. And so I was passionate about putting it together on kind of the administrative side. I got kind of drawn into teaching almost accidentally. I was more interested in kind of knowing more. And so when I was kind of, I guess in those years when I was in Oregon, I did a lot of CE, and I ended up in Seattle studying with Frank. I was in the office with Frank and Greg Kinzer. And during this same period, I actually went down to Pankey, and I went through all the Pankey curriculum. And that's where I got to meet Steve Ratcliffe and Gary D. Wood, both who are part of our faculty here. So I think a lot of your guys may recognize those guys.
Absolutely. Absolutely. And so as you got involved with them, it really wasn't a difficult jump, it sounds like. Basically, you already knew kind of about the philosophy that they were interested in, and basically you were able to bring more to the table, though, from your training, I would say. And it looks like based on the courses that you're teaching, that you're focused a little bit more on maybe edentulous or soon-to-be edentulous patients, and you teach some seminars as well as get involved with some of the workshops. Is that right?
Yeah, I think one of the things that I really bring to our team is the full arch aspect of what we can do. So you look at Frank's work over the course of his career, really heavy into fixed reconstructions, particularly teeth, but also teeth and implants. And so Frank, during his career was able to see kind of the introduction of implants into North America. By the time guys who are kind of the vintage of Greg Kinzer and me, I'm leaving Bob Winter out of the conversation for right now. He's in the middle, but Greg and I kind of same vintage. And so we've dealt with implants for a good part of our career. Greg, kind of looking at both of our career trajectories, Greg went directly into his pros residency straight from dental school. I took a detour. I went to private practice for 16 years before I did my residency. Greg, Frank, Ricardo, and Bob both have a long history with University of Washington, and I'm bringing some of the concepts and the traditions from UCLA to the team. So one of the holes that I'm really able to fill, and I'm doing that now with Ricardo Matrani, is some of the full arch edentulous restorative stuff, and especially with kind of the modern applications, things we're able to do now that we weren't able to do really predictably in a general practice, I'd say, 10 or 15 years ago. And that's awesome. Honestly, that's one of the reasons that I wound up wanting to go back to the residency, because I as I got interested in trying to help my patients who needed, full reconstruction with an edentulous arch, what I found was continuing education was really incomplete for me. There were a lot of technique courses. So you could go and learn a technique, could be fixed, could be removable, but it's really going to be one technique, and for the most part based on that person's opinion. They're really tough to find something that would give me as a clinician, give me an overall view of what the options are for different patients and how I could then select what's going to be the best or maybe the most appropriate option for any given patient.
Nice. So you were looking for that through your training, and now after kind of filtering that through, you're bringing that to the seminar and bringing that to the workshop. And that's a pretty awesome intro, Wes, because that's kind of what we're about in our show, is talking about the things that are possible. And we also want to be research-based, science-based. So I think that's one of the reasons we connect with Spear so well, is it's a good combination of modern techniques that are based upon research. And that seems to be a hard balance to find in the CE world these days.
It is difficult to find these courses that provide maybe a comprehensive look at what is available for patients today. And I think that brings us to our topic today, and something that Jon and I are very passionate about is really just to steal a little bit from your title of your seminar is treating the terminal dentition and the fully edentulous patient. It's right up your alley, and we're excited about to discuss it with you. And so let's get right into some areas that we might agree or disagree, or even we may not disagree or agree, but there are a lot of controversial subjects surrounding like material choice and lip support and when we choose one versus another. I know there was some questions drawn here recently at the Academy of Osseointegration of whether or not zirconia should be used in full arch situations or not, because of long-term studies haven't been shown maybe to predict what could happen. But let's start by kind of breaking it down, and maybe we can kind of go through this a little bit for our listeners. Is what are the ideal for you and minimum number of implants for each arch for, let's just say, maxillary versus mandibular? Let's start with that simple question. I know that's loaded. That is loaded, man.
Simple
that's got
question,
like so much content right there, right there.
All right, let's see if we can break this down. Because what you're asking is, you're really asking for the silver bullet, or the magic kind of one size fits all approach for all of our patients. And what we have to remember is that each patient's going to bring a set of clinical circumstances that are going to be fairly unique to their condition. So we have to consider things like, going back to facially generated treatment planning, how do the teeth relate to the rest of the face? And so our first step is determining where do we want to place the teeth? And then how do we want to basically keep the teeth in? So we're going to go with a fixed solution or a removable solution. And then based on kind of that idea, what's the bone giving to us? What kind of support situation do we have? What's going to be maybe a best fit model to support the teeth in that position? And so that can really help us kind of go down the pathway of whether or not I need to use removable, or this is a case where I could use fixed. Optimal implant numbers, I'd say, on the mandible, let's start on the mandible, because that's really the easiest arch to deal with in many ways.
Right, because it is the most predictable area as far as bone quality. We know that, in our anterior mandibles, typically we have for our listeners is a D1, D2 type bone, and that's where most of implant research has been done. Longest term research, let's just say, is the anterior mandible. And so let's start there.
Yeah, I mean, this is the original Brandemark approach, right? Looking for a solution for the mandibular complete denture. And in terms of predictability, right? Predictability doesn't mean good or bad. It means the outcome is what I expect. I get what I thought I was going to get. And with a lower complete denture, they're generally pretty terrible. So that's predictable. But if we're looking for alternatives to a lower complete denture, a conventional denture, a 2-implant overdenture is a really killer solution if you're opposing a maxillary complete denture. If you're opposing natural dentition, a 2-implant overdenture may not be effective for a lot of patients. So in the mandible, because of the bone situation, we know the anterior mandible is really predictable in terms of implant integration and long-term durability for implants. So 2-implant situation can be fine for an overdenture. A 4-implant configuration, generally, you could use that for an overdenture. It's going to depend on what you have on the maxilla and what kind of forces you're expecting for the patient, and frankly, the patient's ability to keep their restoration clean. We were trained classically at UCLA for a 5-implant configuration for a mandibular hybrid. That's an effort depending on the configuration of the arch, a U-shaped versus a V-shaped versus a, let's say, a more squared off mandibular arch. That 5th implant near the midline can many times allow you to increase your AP spread, and the thought would be then it would give you more predictability, long-term durability with your distal cantilever. So 1 implant has been proposed on the mandible. Haven't tried that yet. There's some research that indicates that can work. We talk about it in both the workshop and in the seminar. Is
it a little cowboy? Is it a little cowboy? Just go ahead and say it. Call it out. It's cowboy.
To me, to use 1 implant is like, it's a rescue, right? So if you got a patient where you only got 1 implant site, and they're, faced with 1 implant overdenture versus a complete conventional denture, use an implant, go for it. But, if you got everything else going for you, I'd probably do something other than a 1-implant configuration.
Now, while we're on that topic real quick, before we move to maxillary, I just want to ask your opinion on if you're doing overdentures that are unsplinted implants in the mandible, what do you think about, say, take locators, for instance, because we use them so often. A lot of people talk about adding more than 2 implants for unsplinted overdentures. There's a question about adding retention versus adding additional fulcrums that potentially wear locator attachments out. What's your feeling on, say 3 versus 4 versus just 2? Do you have a feeling on what you would recommend there or what you teach there?
Yeah, we actually talk about that quite a bit in both the workshop and the seminar, because sometimes adding more implants is not the best solution. So really, as far as troubleshooting goes, let's say you've got a 2-implant locator overdenture, right? So individual attachments, they're not hooked together, they're just locators directly on the implants. And if the patient's struggling with that, you really want to try and identify, are they struggling with it because they can sense the compressibility, or are they struggling with it because it comes out too easily? And depending on that, identifying the cause of that problem, that's going to help direct what you want to do to deal with that. Again, gotcha. 2 implants going against a maxilla that's got a conventional denture. On the mandible, I think it's probably, the research will back up that, it's okay to go with individual attachments. The thing that we get implant researchers and clinicians both get concerned about with individual attachments is the amount of force that's going to be directed to the implant and then to the implant bone interface, and the potential for overloading is what we're thinking about. And, you know, in the mandible, we're fortunate because you can almost do whatever you want. With the right patient, there's a lot of things that we can get away with there. So
basically,
what
you're saying is that don't have tunnel vision as a dentist when looking at edentulous patients. You need to look to the opposing to see what's going to happen. Either is it a full arch situation opposing? Is it a fully edentulous patient? Is it a patient that has a complete dentition? What kind of forces before you make a decision and say, hey, 2 implants is enough, 4 implants is enough, 5 implants is enough. And
it comes back to treatment planning, which is what, you know, is the hallmark of what you got, the way you guys teach.
Yeah. And if you know, your point is just really well taken. The first point to really begin any of this stuff is going back to your treatment planning. And as clinicians, you know, we go to, okay, can I use 2 implants, or, you know, should I put a reinforcement mesh inside this denture or whatever? But really, if we're thinking about the mandible, the place to start is the maxilla.
There you go.
Where do we want the teeth to be in the maxilla? And if they're not in the position that we want them to be, we have to get the occlusal plane corrected first. And that's going to help us identify what kind of space we have to work with on the mandible. And then the space that we have, or the space that we may be able to create, will help us when we get to our structural part of our treatment planning.
And I think 90%, if you talk to dental laboratories especially, 90% of the problems that they see are the lack of what you just described. It's not...
Oh, for sure.
It's the problem of improper space, vertical space. I mean, that, you know, how often do we see that discussion happening where, you know, what can I... Now the implants are placed, and we're very limited on what we can do. And if someone would have looked at the fact that we had combination syndrome and we had super erupted posterior maxillary teeth, we would have, or a denture that's, you know, down 7 millimeters in the maxillary posterior, we would have thought very differently about the mandibular treatment plan. So I think that's the key. And if anything we get from this from our listeners, it's, you know, begin with setting denture teeth, just like we've talked about on the show many times, is where do 8 and 9 need to go. Let that drive your treatment plan. That's where Spear does so well. So what about the maxilla? Because it is a lot more variable. There's a lot worse bone quality potential there. How many implants do you look at as maybe your minimums or your ideal situations for some of those same scenarios?
The maxilla is really the Wild West. If you, I mean,
yes,
it is. If you look at the mandible, we get a lot of long-term research, just a ton of it on what happens with implants, what happens with different configurations of implants and different restorative designs and those sorts of things. When it comes to the maxilla, there is such a difference in the way that people restore edentulous maxillas that it's really difficult to put together enough research to do a review. So you don't see a lot of clinical reviews or systematic reviews for edentulous maxillas that can give us as clinicians really any helpful guidance, because people are kind of doing whatever they feel like is going to be most appropriate. So in the maxilla, you know, where do you start? Well, you're going to start with where do 8 and 9 go. And so you're going to begin with the incisal edge of the maxillary anterior teeth. You're going to develop the incisal plane of the maxillary anterior teeth. And then you're going to finish out kind of figuring out where you want the maxillary occlusal plane to go, right? That's going to allow you to work apically now and identify where you'd like the gingival margin to be, depending on the tooth length, and particularly the anterior. We can work then from the gingival margin, or from the soft tissue levels. Now we can work back towards the ridge and figure out, okay, how are we going to actually design this restoration in a way that the patient will be able to keep clean? And there are some patients, depending on the ridge to tooth relationship, that we can't really create in the maxilla a restoration that's going to be able to be cleaned at home. And so for those patients, you know, maybe fixed isn't the right solution.
So let me interrupt you just for a second. Jon and I just recently interviewed, and if you're listening to this, it was just the last episode, and it was we interviewed an inventor of a dental implant. And he kept bringing up, because I just listened to the episode today, Jon, he kept bringing up cleansability and predictability. how good is the patient's hygiene. And basically what you're saying here is you're saying, well, let's look at aesthetics. Let's look at the position of 8 and 9. But then let's take a look at how well they can clean this. And I think that's the thing with dental implant dentistry is that we don't know how to treat peri-implantitis. And we've said it time and time again, it's not a predictable thing. And the patient's hygiene is really starting to determine what type of restorations we should really be providing our patient. Is that the case? And is that why you've brought it up as point number 2?
Yeah, for sure. Clark Stanford, this is going back maybe...
Love that guy.
Yeah, he's awesome, right? He's got a work group. This must be the AO, Academy of Osseointegration.
Yeah.
Got a work group looking at the edentulous maxilla, right? And it really kind of brought up a nice way of thinking about the edentulous maxilla, because there's levels of difficulty that are going to be required from each member of the clinical team. And that's going to include the patient. So we got the patient, the restorative dentist, the laboratory technician, and the surgeon. And each of us on the team are going to experience different levels of difficulty for different tasks. So for a surgeon, if I'm going to do it, let's say an overdenture, I'm going to need the implants to be in a particular configuration, a very particular space. I may ask the surgeon to do something that's technically very difficult. I may ask the laboratory technician something that's super difficult for them to do. If we give our patient what's essentially the biggest, most difficult to clean restoration we have, the conventional fixed hybrid, right? A metal and acrylic restoration. We give a patient a maxillary hybrid, super difficult to clean. And if they're not able to do that, if they don't have the capacity to do that, the restorations failed before it ever got out of the office.
That's a great point.
And I think that's what we're seeing. The problem that we're seeing is the one size fits all concept. And, obviously there's been good and bad about the proliferation of the all-in-4 concept. And, we could talk about, organizations that have advocated that and whether it's good or it's bad. But I think that in the maxilla, we've seen, I remember a couple years ago at the AO, we saw Steve Perel talk about, all on 4, none on 3, and that he had seen so many issues with maxillary fixed. And as he talked about the failures of implants and trying to rescue these cases, it kind of kept coming back to, should we be doing fixed hybrid restorations with a flange? Should it be, outlawed? Do you think that it should go that far, that we should really be saying, unless we have a convex intaglio surface on a hybrid, that we should maybe be careful doing that? Or do you really feel like there's some patients that can handle it? You're seeing enough success with those restorations that you think that we should keep that in our armamentarium?
Well, I think with respect to the flange on a maxillary prosthesis, it's kind of a spectrum, right? There's a degree of how much flange do you have. So if you think about like an ovate pontic, that's really going to be maybe the shape of an egg. And if we were to create the cross section of the maxillary hybrid in that egg shape, it's still going to have a convex surface on the tissue side. Still going to be able to clean it, but it will appear from the facial like it's got a little bit of a ridge lap. Now, that's one thing. Another thing is what you see, I don't know who you guys are friends with on Facebook, but my Facebook is 100% dentists. And all I see all day long are pictures of teeth and things from the lab and stuff like that. And so, I could open my Facebook any day of the week, and what you'll see are these maxillary restorations they've got a flange going both towards the labial and the palatal, and that there's no way a person could clean that. And so that's really something that if we need to create that kind of a surface, that's where I think a removal option is critical. Because even if the patient were to come in every 6 weeks for you or me to unscrew that, disassemble everything and try and clean it, they're going to go home and it's going to start getting disgusting, 20 minutes later. There's just no way for a person to clean something like that.
Yeah. And I think that's obviously, as you said, I mean, it's a continuum, it's a spectrum. It's not to say, but I feel like there's definitely for sure more of a problem with that than that's creating solutions with flanges. I think we're seeing more and more of that.
I mean, you see that stuff. It looks beautiful on the bench, right? You try it in and it's gorgeous, but what's the recall going to be like? And so,
So what do you think?
Yeah, go ahead, Wes.
Well, I was just going to say, so let's just kind of go down to brass tacks here. Like, if
yeah.
we're doing, there's many different types of restorations, and maybe we'll get into a few of those this afternoon in our talk. But let's talk about implants. In the maxilla, is there a place for angled implants? Is there a place for, let's talk about angled, let's talk about zygomatic, which is the ultimate angled implant. Let's talk about shorties, which, we know that everyone is, trying to avoid sinus lifts and avoid morbidity and things like that, and less grafting now is done, more soft tissue grafting than bone grafting.
Yeah, so how does that relate to, I mean, I know we're not looking for you to give us, this number of implants.
No
but
hard numbers, but I mean, like, what are your thoughts on these concepts?
Yeah, if you see these patients who have favorable occlusal situations, favorable vertical space situations, how comfortable do you feel with, 4 implant unsplinted overdentures? Or, if you're doing a fully fixed case, do you feel comfortable with tilted implant concept? Kind of give us a little bit of guidance on where you think we are today.
In the maxilla, I think we've got, reasonable long-term data that says 4 implants can work. It's probably not going to be my first choice. For most patients, as a general rule, kind of my brain is going to 6 implants as a minimum. Mm-hmm. But 4 implants with tilted configuration, you're right, can really a lot of times save us from sinus augmentation, bilateral sinus augmentation, which is going to slow the whole case down. But then, you'd want to understand, well, what's the outcome? What's the predictability long-term for implants placed in a sinus, especially if there's very little native bone? And so then you got to compare that against a tilted implant concept. And, you're going to probably be going with trying to find the best of a tough situation there. Mm-hmm. Getting to the idea of individual implants in the maxilla, man, if you said something like that at UCLA, they'd run you out. In the maxilla, I was trained at UCLA, and my buddy Ricardo Mitrani was trained at University of Washington, and another colleague of mine, Doug Benting, is a prosthodontist here in Phoenix, and Doug Benting and I worked together in the edentulous arch workshop. The 3 of us, we've sat down a lot, and we've all been, had it beat into our heads that should try and connect the implants in the maxilla if it's possible. What's the downside of connecting implants? It's going to require more space. You need to have enough room for the bar. And so it gets to be a balance between, do I have enough vertical space to connect the implants? And if not, is there a way for me to get it, which is typically going to be reducing the bone, the height of the bone. And that comes, at a risk for the patient, right? We're taking then a patient who's got some vertical height to their ridge, and we're reducing it so that we can place implants. A patient who's typically got enough vertical ridge in the maxilla that we think we have to reduce it vertically, those patients tend to actually be pretty good conventional denture patients. So one way to think about that is, in order to place implants and have enough room to connect everything in the maxilla means we're going to take someone who could be a good conventional denture patient, turn them into a candidate for implants with enough prosthetic space, but now they're going to be a terrible conventional denture patient. So what's it going to look like for them 20 years down the road?
What's your experience with zygoma implants? I mean, we have
zygos.
Zygos. We have a person in town that is rescuing failed implant cases from the early 80s, and he is doing some things, high-level stuff. And Jon and I have had quite a bit of experience here treating 4 zygoma cases, 2 zygoma with 3 traditional implants in the anterior, and just a combination of things with zygomas. What's your thoughts on these? I mean, do they have a place in dentistry today? I mean, we think they do. I think it's the same concept, but you've got to really pay close attention, I think, to this placement of this zygoma, or in the zygomas. Go ahead and kind of shed some light onto that.
Yeah, the surgical aspect of that is actually super difficult, right?
Yep.
On the restorative side, once they're there, you're looking at typically an external hex type of a connection. No big deal. That's fairly easy to deal with. But we have to keep in mind that, those implants are super long. And so with zygos, kind of where they are, where do they sit in my box of tools or my bag of tricks, a rescue option. Almost never would that be my go-to first choice, because they're difficult, they're hard to deal with if there's a problem later on. And if you wind up going to zygos as your first treatment option, and then you wind up, let's say, losing a couple of them, big problems. So yeah, I use them. We keep them in our bag, but really it's a rescue operation. And once we've gone to zygos, for sure, those implants have to be connected. So you've got to make your restorative design has to take that into consideration.
Well, as we take a short break from this interview, and a lot of what Darin's talking about, Wes, it all comes down to having a team. And, he's talking about how a good lab technician should be a critical part of your team. And we definitely agree with that. And, we've found in our offices that it's one of the first places we go when we're starting a case. I mean, Wes, when we're talking about these difficult fully edentulous cases, the Dental Crafters Network is the kind of place you can call, and immediately you're going to find somebody who knows how to help you plan these cases and execute them.
Before you even start your case, before I even start my case, I call the Dental Crafters Network and I ask to speak to the people over there, and we're looking at the case together before implants are even dropped, because it is all about, John, what we just said, it's about that wax up. Yep. And when you can do it predictably, digitally, and you can merge it back using the best software on the market, Co-Diagnostics at Implant Solutions, and you got the Pros guys over there in the Pros lab that are excellent at setting denture teeth, and they're saying, we need this much vertical, and you see that on the screen, it's amazing, John. It's amazing.
Yeah, and it all comes back to, as we're talking about, restoratively driven treatment planning, and you're going to get that from the Dental Crafters Network. So what we always say about the Dental Crafters Network is that this is the kind of place you need to check out, and we're proud to say that they're sponsors of our show. We endorse them because they're doing it right. If you want to get in touch with the Dental Crafters Network, you can call 1-800-472-8302, or you can go to dentalcrafters.net. Dental Crafters, one relationship, infinite possibilities. And now it's back to the interview. So a lot of this discussion, and I want to come back to the material choices, because there's a lot there. I mean, we don't want to shortchange that, but I think before we get into that, we're about to get, and we've already gotten into some pretty high level discussion here about some of the understanding that it takes to be able to successfully treat these types of cases, or just to be able to understand. And we haven't even gotten into materials at all. So what I think Wes and I really want to know, there's so much discussion right now you see advertisements from laboratories about how easy it is to do an all-on-4 restoration with the price right next door. And you see advertisements, full-page ads in newspapers, and you see television ads. What do you think general dentists need to do to be qualified to be able to perform these types of restorations? I'm not talking about a certificate kind of thing necessarily, or maybe we are, depending on what you think, but what do general dentists need to be able to do in order to really be able to do this at a high level?
That's a great question. And that's, it's kind of getting to one of the reasons why I went back and did that residency, right? I think, let's take a digital concept. So you've got an edentulous case, and the case is going to be planned. In the digital world, we're going to use a guided surgical approach, and we may even have the interim prosthesis, the temporary hybrids, can be fabricated ahead of time. So like an end sequence type of an approach.
Oh yeah. Oh yeah.
Let's say that goes perfectly. The implants go in exactly where you thought they were going to go. The depth is fine, the angulation's fine, everything's perfect. Case drops in, patient's happy, and you can move forward. A laboratory technician can walk you through that if you've never done it before, if you've got an experienced surgeon working on the case. A dental student could handle that. But what happens if something goes wrong? What happens if there's a deviation from that plan? Let's say an implant has to go deeper, or it's got to go into a different position, the angulation didn't work out, or maybe something just went sideways in the planning. Now the challenge comes in for the restorative clinician, because this is where you and I, and I think a lot of your listeners, this is where we have to be able to troubleshoot, figure out, okay, what went wrong and how am I going to course correct? And that goes back to being able to understand kind of the analog world of doing a hybrid conversion, where we would take the patient's existing, let's say, conventional denture, and then convert that into a temporary hybrid. Right. If you know how to do that, you're comfortable doing it, doesn't freak you out or scare you. You know it's going to take a long time, but it doesn't freak you out and scare you. And you have the denture present so that you can do it, then no problem. I think you'll get along just fine. But we've got to be, in order to really do this stuff, as you said, at a high level. But I would say, for me, a high level for a restorative clinician isn't to make a showcase, a case that's going to look beautiful on a huge screen. It's so that I've got a patient who's going to get this treatment, and I can do it in a way that's predictable, so that I don't get killed by having to redo the case and losing profit, burning dollars, trying to remake restorations, and have a patient who's upset because I promised that they'd have something fixed the day of surgery and we couldn't provide it. So those are the kinds of things that I worry about. And those are the kinds of things that we really try and address in our workshop as well.
I was just going to ask there, do you feel like you can do this without taking hands-on courses or doing this hands-on? I feel like that's the thing that is, I mean, you're right, lab technicians can walk you through a lot, but should they be? It kind of bothers Wes and I a little bit when we start talking about these things. Oh, it's easy. It's not easy, because there's two levels to this. The one level is the actual understanding of it, which sometimes is really the problem. But then can this be done should this be done with a lab technician doing the conversion and walking you through the case? Is that, I guess we worry about if that's the way we're heading.
Yeah, I don't disagree with you. I think what we're seeing is pushback or trying to lean in on the part of a lot of accomplished laboratory technicians who are doing these cases and finding that they're having the same sorts of problems in the laboratory. And understanding that if they could step in and intervene on some of these cases early on, they may be able to lessen the headaches that they face.
Yeah, I get that for sure.
So I don't think that restorative clinicians should allow for the case to be driven by either the technician or the surgeon, and quite honestly, really even by the patient. The restorative clinician's ultimately going to be the one who's on the hook for long-term for the restoration. And so we have to be involved in the treatment planning. We don't have to have all the answers to every question, but we've got to be involved in the decision-making from the earliest moments all the way through the case. And that means, for lots of us, it will require some additional training. Most of this type of case planning is based around determining tooth position. And you guys know this, that's all coming from complete conventional denture understanding. And unfortunately, that training's been lost or is in the process of being lost in a lot of dental schools. So I think there is some value to having some additional training in removable pros, conventional old school removable pros, just from that standpoint.
Yeah, man.
I 100% wholeheartedly agree with what he just said, because I love dentures, and I had a prosthodontist that took me under his wings, and in my fourth year, and for my entire fourth year, I learned modified branching technique, and I learned how to set teeth the right way. and it changed my career. If I could go back and like hug the guy, I would. And there is such a barrier between like setting teeth and what that can do for you. And because it's like everybody doesn't want to learn to set teeth, but it is so crucial. What he's saying, Jon, is so crucial to these cases. And
well, and just the old school lab work of, do you know how to do a partial repair in your office? If you don't know how to do a partial repair,
then you better not
should
be
you
doing
be doing
a hybrid
a conversion, and this is the thing that we're seeing a move toward is, well, I'll pay the lab tech. And I understand what you're saying. I mean, Darin, your point is well taken, that the labs they see that they want to avoid a train wreck. They want to be in the room. And I get that, but it's the responsibility is in the end not on the lab, it's on the restorative doc. We just believe that people need to be seeking out a high level of education and understanding, and not and part of it is just the financial drive in a lot of this situation. We get that, but we're gonna get off on a tangent, Wes. We gotta back off.
Darin,
It's gonna get crazy.
I gotta ask you something. You said you practiced for 16 years as a general practitioner before you decided to go back to school.
Yeah.
And you said one of the reasons that you went back to school was to learn this high level stuff. And were you seeing problems and you were like, I've got to figure this out and I've got to know how this works? Was that the main reason? I mean, kind of.
Yeah. Was it a desire to teach it, or was it personally you were saying, this is what I want to be doing more of, so I want to understand this? Tell us kind of what that was about. Yeah.
Well, I had a pretty good handle on aesthetics, ceramics, fixed reconstructions on teeth, and even single tooth implants. I had that pretty well down. If you look at our curriculum, we do a killer job of that on campus at Spear. But what I felt like I didn't know enough about was full arch reconstructions for edentulous patients. And that's conventional removable, that's removable on top of implants, and that's fixed. I didn't know how to make sense of what all the options are. And in fact, I didn't even know what all the options were for patients, let alone how I would go through step by step to actually complete a case like that. So that's, when I couldn't find, I just couldn't find continuing education that could answer those kinds of questions for me. So that was, kind of one of the drivers. Now, 3-year advanced pros program, and I'd come out of private practice. I had a handpiece in my hand, between 180 days and 300 days a year for 16 years. You get into your grad program, I didn't pick up a handpiece for months. It was all removable patients, all edentulous patients. So I set, hundreds, not hundreds, but I set tons of arches. And your compression molding, compression packing your own dentures, processing everything. So start to finish on conventional dentures, you kind of know everything. And that's not so you get to be a killer removable technician. It's so you get to understand how tooth position relates to everything else. And then the next 2 years is relating that tooth position to all your other types of prosthetic designs. So,
wow. Well, that really, that answers a lot of, if, we're talking about how do you get there from here. And, the thing that, again, we almost got off on a tangent on is it's really hard to watch these things happening and just kind of seeming like they're spiraling out of control. Every time we talk to our lab technician, I just talked to him today. I got to tell a 30-second story. He said he was in trying to teach somebody how to take an open tray impression. He spent an hour and a half trying to teach him how to, verify that the coping was seated and just do the, and then the guy, he leaves for 20 minutes after the guy has the impression in the mouth, and he comes back in later and the impression copings are sitting on the table next to the impression. And he said, what happened here? And the guy said, well, man, it was really hard to get that thing out. It's an open tray impression, you're supposed to unscrew the screws, man. And it was improgum, and he just had to rip it out of them because he didn't understand. And so we have the lab technician in here trying to solve this problem, but in the end, it's the lack of training. So if you're a dentist that's, say, a new dentist, or somebody who's got the 15, 16 years of experience, where would you point them to start their training? And obviously, we want you to talk about what you're doing, But are there, besides what Spear's doing, and I want you to talk about that, but also, are there organizations that they should be involved with? Are there journals that they should be reading? Can you kind of tell the new dentist and maybe the experienced dentist, where should they start?
Yeah, it's funny because to the first part of your question, that the way we think about this is for a new dentist, right? And when I was at UCLA, I was working with the pre-doctoral students at least one day a week, and they get a lot of single tooth implant dentistry, at least at UCLA in our curriculum. And so those students are coming out of our dental school in LA with more implant experience than some clinicians who've been in practice for 30 or 40 years. Because for those clinicians, implants came at some point after they were graduated from dental school. And so this concept, where do we get additional learning about implants, can apply to anyone at any stage of their career, depending on what their experience level is. So I would say, one place to get a lot of additional education about implants would be to do a residency. If I was looking at a new grad or someone who's getting close to dental school, I would say, think about doing some kind of a post-grad residency, either an AEGD, a GPR, or advanced pros, if you're interested in the restorative side of dentistry. But if that's not something that you wanted to do, there's a lot of really good continuing education. So I mentioned earlier, I was with the Academy of General Dentistry in Oregon. Depends, kind of varies by region, but our state unit there, we had a lot of really good continuing education. And I'll call out one of my kind of really good friends and original mentors is Tom Walker. And he's a restorative guy. He's a little bit older than me. And I took a 1-year kind of crown and bridge study club with him, and I learned a ton. I learned a ton about the clinical aspects of dentistry, but I also learned how to kind of think about learning new stuff as it becomes available for the rest of my career. It really set the stage for me to go on and do a bunch of other stuff. So with that in mind, we've got a couple of different modes at Spear for education. We've got lecture formats that are, it's kind of fits the middle of the road in terms of cost. We got hands-on workshops. And if you look, I'll say the edentulous arch workshop, what Doug Banting and I have tried to do with that workshop is really give you that part of the curriculum that a person would find if they went into a grad pros residency right now. We're trying to, in 3 days, give you kind of that first, second, and third year of your grad pros training that's going to relate to that. Mm-hmm. But we've got a lot of online resources too. And so our Spear Online platform is really, we're continuing to grow that, but we've got stuff that is more kind of at the basic level, beginner level. I shot some courses a little while back that just discuss exactly what you're talking about, that how the differences between open and closed tray impression copings and how clinically that is going to kind of give us a totally different approach to making the impression. So we try and kind of have high level stuff, but also I'll say more kind of introductory stuff.
So what you've heard here as mentorship is decreasing. We are ever really looking for, the place to go to learn these high level things. And if you're listening to this show, we're excited to, bring you this exclusive interview really with somebody that, Darin, we think you're doing it at a high level. We think you're doing it right. And we think that you went about it the right way. The repetition that you talk about in pros residency of doing that many denture setups, that is invaluable. And Jon and I have talked about how that reps make a big difference in training, just from a standpoint of crown and bridge, learn to trim your own dies and understanding, that aspect of just how margin integrity can improve just by trimming your own dies. You don't know what you don't know until you see your own work under a bench microscope and you're sitting there studying it and you see what effects it has on the patient from a day-to-day basis. And
that is for sure.
And
it's humbling. It's humbling.
It's very humbling to look at your margins under a microscope and be like, "Whoa, that was me? No, that's not cool. Let's go back and do it again." And so, I really appreciate, and Jon and I really appreciate you coming on our show, Darin. And you've really, talk about a topic that we just love is dental implants. It's one of the greatest things that have impacted our practices, is to be able to provide patients with really a restoration that can change somebody's life. And but I think what you said is well taken, in that it requires a significant amount of training, and there are places that he mentioned here that I think are that you can go to. So for our listeners out there, if you have questions regarding our topic today, you need to go on to our Facebook page, send us a message. You can leave a message in our YouTube comment feed. You can tweet at us at the Dental Guys, and we'll be sure to pass that along to Spear Education and Darin there. And Darin, do you have any handles that you'd like to pass along to our listeners, and maybe how they can get in touch with you?
Yeah.
Just straight through Spear, right? I would think
through
if
Spear.
Wanna,
I mean, do you want to do Spear?
The easiest way is to come through Spear, and it's the easiest way to get a hold of me. The first thing I do in the morning is go through a stack of emails, and
right.
So I may not get back to you right away, but I certainly do my best to do that. And so my contact information there is D, and then my last name Dichter, so DDICHTER at speareducation.com. And I'll certainly do my best.
And I think if you really want to get in touch with Darin, just come take the seminar or workshop, right? I mean, that's the obvious thing here.
That's true.
We got
just make sure that you mention that Jon and Wes introduced you to Darin.
Yeah, there you go.
And that goes a long way for us. Not really, but no, we're humbled. Actually, we're very humbled to have you on the show. We thank you so much.
Thank you.
And for Wes, the dental guy, and for Jon, the dental guy, and for our honorary dental guy, Darin, we appreciate you listening to this show, and we are the Dental Guys.